Our next speaker, Mark Menolascino. Is that good? I had to get out my New Jersey Italian for that, right? Dr. Mark, as he's affectionately known. What's that? Looks just like his picture, yeah. I think his hair is a little longer. He looks a little cooler now, you know. Thank you. Beautiful. Dr. Mark completed medical school at the University of Nebraska Medical Center and completed his internal medicine specialist training at Banner Health Barrows and Mayo Clinics in Arizona. He's one of the few physicians that is actually board certified as an internal medicine specialist, board certified in holistic medicine, as well as board certification in advanced hormone management and anti-aging medicine. Additionally, he has a master's degree in pharmacology and immunology and was a doctoral candidate in the medical science program assisting with clinical trials of new medications, as well as part of the heart disease reversal team with Dr. Dean Ornish. His medical knowledge is complemented by advanced training and clinical experience in nutrition, naturopathic medicine, Chinese medicine and acupuncture, Ayurvedic medicine, and homeopathy. Dr. Mark's talk will be on identification and nutraceutical management of emerging cardiovascular risk factors. Okay. Did you want to come up? Yeah. Dr. Mark.
Well, thank you for the warm welcome. It's great to be up here in Glacier Country. I'm from Jackson Hole, and we have some nice days like you see up here, and I hope you guys get a chance to see a sunset like that while you're here as well. What I'd like to talk to you about today is I was very impressed by our first two speakers, and I think we saw some really good hard science as well as some good clinical discussion about what we're doing is working. And that's my message I really want everyone to leave with today, is that as a boarded internist, two of my brothers are internal medicine specialists, and they're very holistic hearted, but they just don't get it. They don't really understand this integrative model. They think adrenal fatigue is adrenal insufficiency, and I really respected David's comment about, you know, you can't follow the same caterpillar trail every single patient. Not everybody has adrenal fatigue, not everybody has T3 syndrome. You really have to look at this holistic individual, have a bigger bag of tricks than the doctor next to you, but really not put your flag too high in any one hill. One of the things that got me to be a doctor was Dean Ornish. He came to Omaha, Nebraska with this crazy shirt and big afro from San Francisco and said, I'm going to take 100 men who have had heart attacks and they're scheduled for 3-vessel bypass surgery, and I'm going to talk them out of it. The doctors in Omaha went ballistic. I thought it was pretty cool. I went and had lunch with him, and we became friends. And guess what? 25 years later now, there's more people still alive in his group. Less recurrent heart attacks, less medications, less hospitalizations, higher quality of life. And on angiogram, he's shown to reverse the lesions. So that's the message for all of you out there, is that what you're doing works. But again, don't plant your flag too high in any one hill. Be open to new things. Come to these conferences. I remember the first medicine conference I went to, the lecturer told me what he did, the results he got, but that's about it. The first holistic medicine conference I went to, they told me what they did, the results they got, what supplements they used, what patients they used, the way his medical assistant worked it up. He gave me the protocol sheet, he gave me a cell phone, and a big hug at the end. That's the difference between what we're doing and what the others are doing, but it doesn't mean that medicine is wrong. When I need acute care, when my kids need acute care, thank goodness it's there, and medical technology is an amazing thing. But it just seems as time goes on that the flag is planted too high in that hill. And that's some of the data that I want to show you today. So truly, as Hippocrates said, let food be your medicine, your kitchen be your apothecary, your lifestyle be your doctor. That's the mantra for my practice. Yes, I have a wall of supplements, but I try not to have people do this. As David said, they come in with their trash bag of supplements. This is one of my patients who had diabetes and was diagnosed with heart disease, hyperlipidemia, was overweight, arthritis, and you can see calcium, turmeric, niacin, cinnamon, all the usual things that we hear about. And again, that's a toxic liver load. What I try to do is to say, what foods can we use as these medicines, and not try to use the supplements, but use the supplements to get them to the point where food actually can be their medicine. So focus on the white dot because, again, the flag is pointed in any one hill. I hope that bothers you as much as it does me. So one of the things that we realize is that it's not about cholesterol. It seems how shocked I am by having these people who come in from Canyon Ranch and the Mayo Clinic, and I remember the head cardiologist at the Mayo Clinic beating into our brains that it's all about cholesterol. Statins should be in the water. They should give a statin away when they give a Big Mac away at McDonald's. And there's a lot of people who still believe that it's all about cholesterol, it's all about giving people statins. Well, we know from the Framingham study, it seems the longer the study's gone and the more we analyze it, the more we realize they were wrong. It is not about cholesterol. At least 35% of heart disease will happen in people with a cholesterol less than 200. I remember the first sudden death heart attack that rolled into the Banner ER my first week in residency training. He had a cholesterol 188 and he was a marathon runner, just like Bill Fix. You guys remember Bill Fix? And I remember shaking my head and asking my attending what the story was. He said, well, it must be family history. Well, what do we know? You're not your genetics. It's not about your nature. It's about your nurture. This is what a plaque looks like in a nice color radiology film. And what I tell my clients is that I draw a picture on a piece of paper. I show them this, and I draw the picture on the piece of paper. I do a little line on the inside to tell them about these special cells that line these blood vessels in our arteries. And I show them how I used to think that you filled that whole artery up with plaque, then you had one more Big Mac and it knocked you off. That's not the case. What happens is you get plaque that develops. It's a hard-covered plaque on a soft cholesterol goo. The inciting event is plaque rupture. Platelets come to the rescue to try to fix that plaque rupture. They overreact, create the thrombus, boom, there's your heart attack. So you take an aspirin to block just enough of them so that they fix that hole but not plug the pipe. That's a great analogy for to use with your clients. They get that. So what's good about HDL? HDL scours that hard plaque and makes it smaller. Why is LDL bad? It increases the size of the goo inside of the plaque. Why is C-reactive protein the most important thing in your body? Because it's what's going to be causing that plaque to rupture. Why is homocysteine a risk factor for Alzheimer's and heart disease? Well, they're not cholesterol problems. They're inflammation problems. Heart disease is inflammation of the heart. Alzheimer's is inflammation of the brain. And if we really address health that way and help people to get something simplistically figured out like that, you get them to drink the Kool-Aid. And once they've drinking the Kool-Aid, they're going to make decisions. I don't know if the supplement I gave someone made them better. I wonder if the fact that they're taking the time to open a bottle and take a supplement in the morning will make them grab an apple instead of a candy bar, will make them park a little farther in the parking lot and walk in instead of taking the escalator up to 24-hour fitness. You know, will they do these other things behaviorally? And I became an internist because I was so impressed as a med student when someone would come in and say, well, in the Jupiter 2009 trial with 38,000 placebo-controlled randomized multi-centered meta-analysis trials, these are the results that we got. And the longer I'm an internist, the longer I'm an integrative doctor, I have not much use for evidence-based medicine. As much as I would love to have evidence-based guide everything I do, I think it's a fallacy that we're trying to conform everybody into one parabolic curve. We're trying to regress our population as individuals to the mean of a population, not treat them like individuals. And again, it's strange hearing internal medicine doctors say this. My two brothers hate it when I talk about it. But the reality is, I'm not sure there's really good evidence-based medicine being done. You saw some great data from our first speaker today, and I love that data. I'm so impressed that someone like that has his hands wrapped around all that data. But really, most of the studies that are being done in America are sponsored by Big Pharma. Most of the studies are positive publishes. We're not seeing the negative studies. And the more we go back and look at what all the studies show, we're less and less confident about our science. Well, what's the gold standard in America for heart disease? You get the blood thinner, you get the diet and exercise, the cholesterol medications, management of blood sugar and blood pressure, and then you end up with a stent and a coronary bypass graft. One of my good friends is Mimi Guarneri, who runs the Scripps Integrative Center, and she started as a stent maker. She went to Scripps because that's where they invented the stent. She wanted to be the best stent placement. Then she realized she was doing stents in people who had bypass surgery. Well, how can that be? It's because what happens after your bypass surgery? You leave the ICU, you go up to the next room, they give you a roast beef sandwich full of mayonnaise and baked potato. It's the wrong model. And she finally woke up and drank the Kool-Aid and realized that there's a better way. It's a better way to look at the prevention for this. The problem is, how scientific is scientific medicine? This is Marcia Angel, who is one of the editors from New England Journal of Medicine. It is simply no longer possible to believe how much of our research is published or to rely on the judgment of trusted physicians or authoritative medical guidelines. I take no pleasure in this conclusion, which I reached slowly and reluctantly over my 2 decades as an editor of the New England Journal of Medicine. Again, not every study is bad, but again, if we're trying to hang our hat on this evidence-based model of medicine, we're going to miss the boat. In '78, the Office of Technology told us that no more than 15% of medical interventions are supported. That's not very good. In 1991, the editor of the British Medical Journal said 1% of the articles in medical journals are scientifically sound. David Grimes in '93 in JAMA said much, if most, of contemporary medical practice still lacks a scientific foundation. I was told 2 things the first day of my training in medical school. The first thing they told me was that half of what you learn in the next 4 years will be proven to be false. It's your job to figure out which half. The other thing they told me is that the only way you can motivate people is by fear and guilt. If you don't stop eating Big Macs, you're going to have a heart attack and die. If you don't stop smoking, you're going to get lung disease. I think as holistic practitioners, what our job is to come to conferences like this, network with like-minded professionals, discuss what works in our hands and for our clients, and go back and provide information to our clients to help them gain knowledge, to empower them to change their behavior. That's the new paradigm in health. So, as much as I was just beating up evidence-based medicine, you'll see me shade it because I'll show you some of the bad medicine that's out there. In 2004, there's an article published in JAMA on the use of simvastatin. What they didn't tell you in 2004 is that at 80 milligrams of simvastatin, you had a 61 in 1,000 risk of rhabdomyolysis, whereas it was originally reported 8 per 10,000 in the 40 milligram dose. They did not report the 80 milligram dose in the 2004 article. This just was published recently, 7 years too late. I mean, they knew it in 2004. Why didn't we get told that? Simvastatin 80 is now a black box drug. It is not supposed to be prescribed anymore in America. And we knew it 7 years ago. And again, 61 in 1,000. I just saw a gentleman in my practice that in Jackson Hole, we have this thing, if you didn't climb the Grand Teton that day, you're not really an athlete. We have these I call them cardio psychos. They are just so into fitness, and they're I was climbing the Teton Pass skiing a couple years ago, and I got passed by a 71-year-old woman. And I stopped her. I said, how old are you? She said, well, I'm 71. I've been doing this every day since I was 36. And I was, oh, Father, Son, Holy Ghost, you're killing me. And so we have these people like this. The gentleman came to see me. His muscles were he was climbing the big Snow King ski trail, which is about a 3,000-foot vertical, very steep hill. And his legs were hurting more and more and more and more. And he was on simvastatin 80. And his doctor didn't read the journal article. And so we took him off of it. He's got statin-induced myopathy. CPK, high end of normal, is 170. His was 17,000. He was in acute renal failure, and he may not recover total function. So again, these are dangerous drugs, and the information was known 7 years ago. And so again, that's why I think we got to be careful. Red yeast rice extract, it can do the same thing. So just because it's natural isn't better. And what about red yeast rice extract? This company sponsoring the talk today does not do this, but there's several companies that spike their red yeast rice extract with lovastatin. That's been proven by several companies. So we really got to watch what we're doing naturally. And if you're just trading a medicine for a supplement, you may or may not be gaining ground. It's really all about lifestyle. Here's another good one. Now, aren't we supposed to try to prevent heart disease and sudden heart attack death? But if we're giving a statin and we're increasing the risk of diabetes 9%, that doesn't say 0.9 or 0.09, that's 9%. The number is actually about 8.89, but I rounded it up because I like it. Well, essentially, 1 in 10 people put on Lipitor will develop diabetes. And it's amazing because I had seen this, and I never put it together. In the last month, since this article has come to my attention, I've picked up about 30 people who never had diabetes, never had insulin resistance, they're not overweight, but their blood sugars have steadily climbed over the last 5 years while they're on the statin drug. This is a slide from Mimi Guarneri. I mean, if the faucet's running and we're just mopping it up, we're wasting our time. We got to stop the flow. Again, one of the benefits of being in Jackson, this was the family of moose this is right outside our front door. They spent the entire summer with us. Most moose will have twins. Usually they don't survive unless they have a protected environment. And that's really what David was talking about, is this protected environment. You know, the clothing that we're wearing, the Spider-Man sheets that we're giving our kids, the hormone disruptors that are in our food supply. If you haven't read The Omnivore's Dilemma or been looking at Michael Pollan's books, get on the bandwagon and look what's happening to our food supply and look what's happening to the hormone disruptors and the xenoestrogens that are in our environment. It's just plain shocking. As far as how to eat, I get asked this every single day. I'd say it's a berries, dairies, and beef. If you're going to eat red meat, eat wild game or eat organic beef. It's not as inflammatory. Do not go to Albertsons or Safeway and eat that dye-coated, xenoestrogen-filled, highly inflammatory arachidonic omega-6 piece of meat. It's a guaranteed way to plug your pipes. I can't tell you how many phone calls I've gotten from my clients who say, oh yeah, I'm leaving the Snake River Steakhouse and I'm walking to my car and I'm getting chest pain. Why is that? Because it's a very vasoconstrictive meal. These high arachidonic acid, high omega-6 meals, it's not the meat that does it, it's the stuff in the meat. As far as organic, you know, I love the organic industry. I don't buy organic pasta because I think it's not really in my best interest to spend $14 for a thing of pasta. But when you go to the grocery store and look at organic chicken, the breast is this big, the one next to it is twice as big. You go look at the berries, raspberries, strawberries, those berries are toxic storage houses. So again, if you're going to buy organic, go berries. Dairy, you're going to hear a theme throughout. I'm not a huge dairy fan. I think the whey protein is a big disruptor. Really common to what Dave was talking about, the leaky gut. I can't tell you how many people's thyroids we fixed by just getting them off dairy and or gluten. I do think empiric testing is helpful for that. But if I've learned one thing in food sensitivity testing, if it's positive, you can usually trust it. If it's negative, you absolutely can't. If you're guaranteed someone, if your intuition and the client's intuition, who's always the smartest person in the room, a woman's intuition in my office is absolutely the smartest person in the building. And if you interrupt her within 7 seconds, like most primary care doctors do, and you don't listen to her story and ask her, what do you think is wrong? As William Osler told us, who was the father of the history in physical medicine, if you shut up long enough and let the patient talk, they'll tell you what's wrong and how to fix it. And you guys have seen it. And again, so many women come in, you're the doctor of last resort. I've been everywhere. Here's my Mayo Clinic file. But no one's listened to their story. And once their story comes out, you'll ask them what they think's going on. And so many times they'll tell you that, oh, I think it's my thyroid. And guess what? Your lab tests are perfect, but it really is your thyroid. We also have unique animals in Jackson Hole. So David asked me to kind of talk about the emerging risk factors and nutraceutical treatments, and I'm going to kind of flavor this with a bunch of other things. So if you will, kind of bear with me. We'll kind of ground our way through this and then come back for an overview of what you can use Monday in your practices and what you can share with your colleagues Monday when you get home. It's not about cholesterol, HDL, LDL, and triglycerides. The old 1970s Frieden-Wald equation is bogus medicine in America. You get people come in with these equations where they measured two things, calculated the rest, and that's what they think the risk is. But their ratio is okay, so I'm okay. I don't have to worry about not eating steak and hamburgers. It's really about inflammation, fibrinogen, methylation, insulin resistance, lipoprotein A, the low HDL2B, small dense LDL, vitamin D deficiency. I know I didn't believe the vitamin D data, just like 10 years ago I didn't believe the omega-3 data. I've been wrong about both of those things. There's an epidemic of vitamin D deficiency. When I worked with Andrew Weil in Tucson, we'd have these women come in with leather faces from sunbathing all day and have vitamin D levels of 10. It's so much more complicated because the skin activates it, the gut transforms it, and the kidney activates it. It's a very complicated system. It's probably a hormone, not a mineral. Factor 7, factor 10, some of these coagulation markers. There was a great integrative cardiology in Kona about 6 years ago now, and I called it the Dr. Weil, Dr. Ornish food off, because Dr. Ornish is low fat, Dr. Weil wasn't so much low fat, and it seemed like the entire weekend was an argument between the two of them. about who was right, and the reality is neither one of them were. It's so much more about the individual. Of course, sedentary lifestyle, central obesity. As was mentioned earlier, that fat around the midsection, it is a living, breathing dragon organ machine. It is making tumor necrosis factor. It's making IL-6 and 7 and probably 17 and 18. It's making your C-reactive protein. So I'll have patients that come in, they're a little bit overweight, they have high CRPs, we put them on all the fish oils, all the things that should drive it, we get them on a hypoallergenic diet, we clean everything up, but their CRP doesn't drop. And I finally got an aha, it's the body fat. Once their body fat transitions down, their CRP tends to drop. Not in everybody, but that can be a silver bullet for you. Depression. My master's degree was on, my master's thesis was, you know, when you're sick, when you're depressed, are you really more likely to be sick? We all intuitively know that, but it was never proven. A lot of it has to do with your autonomic nervous system that controls your immune system, that controls your heart rate variability. What's the number one risk factor for sudden death after your first heart attack? It ain't cholesterol, it ain't C-reactive protein, it's depression. What depression does, it takes the variability or the chaotic nature of your heart rate measured by the R to R interval and makes it flat. And that flat, low heart rate variability is a marker of a lot of bad things. In medical school, when we were doing this research on the depression, we had a liver transplant section at the University of Nebraska. We were measuring heart rate variability. We found right before the patient rejected the liver, their heart rate variability would drop. There's been a lot of data looking at bad things happen with low heart rate variability. There's a very simple heart math technique that you can use. It's a finger pulse analyzer. There's the Journey to Wild Divine machine that's out there. There's ways to look at heart rate variability, ways to increase it, ways to protect your patient non-invasively, very inexpensively. Toxins. Mark Houston, I think it was mentioned earlier. You know, Mark Houston is not the alternative weirdo in Nashville. He's a professor of cardiology that runs the Hypertension Institute at Vanderbilt. What does he think is the number one thing behind essential benign hypertension? Mercury. What do I think about mercury? You know, I was told 10 years ago that everybody should get their fillings taken out. I didn't really believe it until I went to a mercury center. I went and visited Sam Queen. I talked to patients of his that were wheelchair-bound, diagnosed with multiple sclerosis, that got chelated and treated and are now running on the beach. How do you make sense of that? Well, if it was true, everybody with fillings in this room would be wheelchair-bound with diagnosed with MS. As David tried to allude to earlier, who's the canary in the coal mine? That's the uniqueness that we just don't have figured out yet. That's where these array panels he mentioned may really come in helpful for us. Not everybody is susceptible and vulnerable to it, but many people are. I saw chelation when I worked at the VA hospital in Scottsdale, and I saw men who couldn't walk a block that got 30 rounds of chelation and they could walk 3 miles. I saw other men who couldn't walk more than a block that got 100 rounds of chelation and could still only walk 1 block. So again, who's going to be the responder to these therapies? It's not a one-size-fits-all. Anger and hostility, response to stress. Where did the type A behavior pattern come from? An upholsterer. There's a gentleman who did the upholstery in a cardiologist's office, and he went to the cardiologist and said, you know, I have to change the arms on your chairs way more often than any other doctor. And it's because the patients come in there and they're all, you know, doing this kind of like me, you know, all kind of a little obsessive compulsive, they're running their things around. And so that was where this whole kind of term came up. But it's type A behavior is not a killer. It's the anger and hostility. The people who are type A and have and hold anger, the ones that blow up and explode seem to do well, which doesn't seem right. But it's the ones that hold the anger in. And anger is probably the most damaging emotion for the body. Caregiver role, this whole idea about adrenal fatigue, I didn't believe it either. And again, not everybody has it. Most of us do. But the caregiver response, we did some work with Alzheimer's patients, and these couples would come in and the husband wouldn't even know the wife, and you could just see her over months and months, it just wear her out. It's that hypervigilance you have when your child is sick. You just never get out of the fight or flight mode. And that has a huge neurohormonal cascade that has all kinds of trouble. You know, the other things that are a little foo-foo, but they make a big deal, you know, why do women live longer than us? What do you guys think? It's their social support. They're social beings much more than the men are. The social support, there were studies done on kids going through college. As they lost their family support, lost their social support, those groups did worse. Having a purpose in life, you know, David mentioned PTSD. I think, again, there's these other emotions out there. We're just beginning to see the tip of the iceberg, and we really don't know how dangerous they are. Again, as was mentioned with these arrays, there's all kinds of new things that are on the horizon. It's really hard to know how to sort the wheat from the chaff. What really is going to pan out to be beneficial? Where are we going to have these panels? Where are we going to have information that guides us? Because it really is very little about your genes. It's much more about what you do with them and what they bathe over them. And again, heart disease, it's the leading killer of men. I sit with clients in my office and we talk about breast cancer, we talk about prostate cancer, and I tell them, you know, I can't prevent cancer for you. I can help you create a body, I can help you create a situation in the body where there's very low levels of inflammation, where your nutrients are optimized so your immune system has its butt-kicking ability, and keep you in a low glycemic index state, a low sugar state, a low oxidative state. That's where cancer doesn't really want to be. But I can't prevent that for you. We absolutely can prevent a heart attack and stroke in America with the technology we have. It's a triad. It's a triad. I call it the Dick Cheney triad because his undisclosed location was about 6 blocks from my house. We had all these guys in black Suburbans driving around looking kind of shady with these glasses and things in their ear. We actually had Army guys that were hiding in the bushes as you drove up to the Teton Park, and they had a missile site. It was kind of crazy. But it's a triad. It's the right blood testing, and I'll show you that. If a husband and wife have chest pain after dinner and go to the emergency room, what happens? He gets a stress test, she gets heartburn medicine. We're naively under-aggressive about heart disease in women. Yes, women have a protective effect prior to menopause that's hormonally based. They lose it at menopause, but we need to be better at heart disease in women. So again, we're all worried about cancer, but we're probably going to die of heart disease, and it's preventable. So the triad is the right test. The other is the right stress test. For everybody in this room, don't ever let your doctor order just a regular stress test. My uncle had one on Friday. He had a sudden death heart attack on Sunday. He was a 10K competitive runner. The stress test, if you're a fit person, is not very sensitive. You need to add some additional imaging. For women, I like the stress echo. For men, I like the cardiolite. The cardiolite is a thallium nuclear test. There's a little radiation. That's why I don't like it for women. The stress echo is better because a lot of women have subtle valvular abnormalities, so you catch that as well. The stress echo isn't perfect. The thallium is pretty darn close. The new technology is the coronary calcium score, or the virtual 3D coronary imaging, where they do 256 slices of your coronary arteries in one heartbeat and reconstruct it in 3D, and look at the calcium that's wrapped around your heart. Your heart's as big as your fist. You have 2 arteries that split. There's basically 3 arteries. If you have diffuse calcium in all 3 arteries, that's a very prognostic good sign. If you got a big hunk of one in any of them, particularly the left anterior descending that we call the widowmaker, and particularly proximal, that's a huge deal. Those are people that you want to get on the Orange Heart Disease Reversal Program. You want to watch those people like a hawk, because those are big risks. Here's the caveat. Again, women have this protective benefit pre-menopause. There's a lot of women getting this radiation CT scan they don't need, because you have a protective benefit prior to menopause. So the way the calcium score works, if a man has a low score at age 60, that's a good negative predictive. If a woman has a high score at age 60, that's a very high positive predictive. Does that make sense? Again, if a woman has a low score, it's a false sense of security usually. If she has a high score, it's a really big deal. If a man has a medium to high score, it may not necessarily be a problem. They were trying to market this as an absolute test for heart disease. It isn't quite, but it's a part of that triad. And if there's something in any one of those pieces, you want to reverse it. Again, the traditional cholesterol, LDL, HDL triglycerides, here's the equation. It's bogus medicine, maybe at the best 40% predictive. In the Framingham study, 80% of all patients with events had panels similar to patients who didn't. It's not about those numbers. I go over this with all my clients about these cholesterol fallacies and myths. I'm going to kind of blow through this for you. We think it's genetic and it's poorly responsive to diet. The correct diet for it is low cholesterol, low fat. There's a bunch of argument about this right now. Lowering cholesterol is the main way to reduce your risk. It's rare in people with normal cholesterol, and we fix on the guidelines because it's easy, paint by numbers. It makes it easy for me, not personal for you. First myth, if my total and my bad are normal, I don't have to worry about heart disease. I just told you about my uncle. Absolutely not true. If I exercise and eat healthy, I don't have to worry about heart disease. Women aren't as susceptible to heart disease as men. The routine cholesterol test gives me an accurate measure of my LDL. If my HDL or good is high, I'm more protected against heart disease. You know, I can't tell you how many women come in and they say, I've got an HDL of 75 and my ratio is 2.2 and my doctor said I have nothing to worry about. Well, how much Premarin are you on? Because we know estrogen drives up HDL. And you don't even have to be on Premarin as a woman to drive up your HDL. We talk about, they'll say, well, I got the good HDL gene. I don't know that there is an HDL gene. It's not so much about those type of things. And if you think that's true, they really can get burned. Dietary risk factors, really your overall calories, low nutrient dense, high caloric density, increased sodium, potassium. The acid load, I think acidity is grossly underappreciated in America, and it's really related to inflammation. They're tied to the same thing. If you're stressed, then you're acidic. If you're acidic, then you're inflamed. Hydrogenated fats, high glycemic load. I teach every single patient about glycemic load in my practice. The OREC value, or oxidative stress state, and cholesterol and saturated fat. I did include a couple extra slides, and I remember when I was sitting there thumbing through my book, being super frustrated because the speaker put in 15 extra slides. I apologize. I believe we're going to get them all emailed to you, so everything that I have here you'll get, even the pictures of the moose. Again, the AIM High study, bear with me on the next two slides. This is something I was talking about with Dean Ornish the other day, and he actually wrote about it in the Huffington Post if you want to go look at it. You know, patients with a low HDL, high triglyceride, they tried to lower the LDL to under 50 by adding niacin to Zocor. There was no benefit in mortality, so it was stopped early. Again, it's this naive approach. What Dean says, he likes the analogy of garbage trucks. HDL is like a garbage truck. So when we block the cholesterol reverse transport, we need to have more garbage trucks to hold the garbage around. That raises the HDL. But if you're blocking a mechanism, all you're doing is getting a traffic jam of those garbage trucks. They're not being more efficient. You have more trucks, but they're not efficient. So again, just raising HDL does not really solve the problem. Because raising it is not always good. If you eat more of a high-fat diet, you're going to need more garbage trucks because there's more garbage in. The Atkins diet, HDL increases as well as LDL decreasing in general, so we kind of called it a wash. But an article in the New England Journal of Medicine showed that even though those numbers balanced each other, an animal model showed more blockages. A follow-up study looked at the Atkins diet and showed no benefit in increased blood flow. The real studies that's shown the benefit are Dean Ornish's studies. He's shown angiogram reversal and he's shown SPECT blood flow changes. So lowering the HDL is not always bad. If you switch to a low-fat diet, you don't need as many garbage trucks. And again, the Ornish program, the only one really ever to prove to reverse plaque and increase blood flow. So really, a low HDL in the context of a healthy low-fat diet is a very different prognostic significance than a low HDL in somebody eating a high-fat diet. So again, even though you have some of these clients that may have a low normal HDL, you've got to fraction out that HDL to see what their real risk is, and I'll show you that next. As an internal medicine physician, I had to put my hand up and swear that I'd follow all the guidelines of the AMA and the UPSFTF, all these task force that try to put us in these evidence-based guidelines to do good medicine for most of the masses. We weren't going to worry about the outliers. We're going to just try to do it for everybody. They did reverse themselves on the high-sensitive C-reactive protein, but they came out and basically said all of these non-traditional risk factors should not be used. Ankle brachial index, fasting glucose, periodontal disease, which one of the comments was made earlier, the carotid intima media thickness, coronary calcification, which I just mentioned, homocysteine, lipoprotein A. I do all of these. Because why not take a global look at someone and try to optimize all of these? Periodontal disease, there's a huge relationship. They've done PCR analysis on plaques from men who've died of sudden heart death. They've found chlamydia DNA PCR analysis in these plaques. Just like the work that Dave was talking about with the gut, finding these bacteria that are driving it. As an internist, I can't mechanistically put that together. As a holistic doctor, it makes total sense. You're a sum of your parts. The third rule he told me in med school to swear by is that I would take you and use the René Descartes model of reductionism and break you down to the very smallest piece I could find that I could fit into a box to pull a drug off the shelf to give you to get you out of my office in 7 minutes. It's the wrong model. This system approach you've heard today is the right model. And so we can't do this for everybody, but a lot of our clients are coming to us, and as David said, you know, when they have a heart attack, they don't need us. That's maybe debatable. But the acute care setting, we have good acute care medicine. They're coming to us because they want to be hiking at 80 with their kids. They want to be active. They want to be optimally vital. I call it the square curve theory. We're told you're going to hit 50 and then be a slow decline to the nursing home, right? Well, I want to get you to your best, keep you there every year until you get hit by a bus your last day. And that's what people want. I mean, this new generation of us that are coming up, we're not satisfied with the traditional parabolic curve to the nursing home. And like I said about the 71-year-old woman that passed me on the pass, people want to be active. I'm boarded in anti-aging. I don't really believe in anti-aging. I don't want to anti-age you. I want to help you optimally age. You know, myself, I don't want to be 120. I want to ski with my kids at 80. I want to ski with their kids when I'm 80. And that's really what we're all shooting for. And that's what you're going to hear this weekend is all about. One of my clients has spent the last 20 years looking for this bear. It's the white spirit bear of Canada. They've been floating in British Columbia, and they finally saw it last summer. They saw it about a week after it was born, laying on the mother's belly, suckling the mother, and they followed it for a week, and they sent me this picture. I've worked with some Native Americans, some spiritual healers and Belize, and you know, there's just a lot of energy out there that we just don't understand. Again, the Frida-Wally formula, the equation I was showing you, as your triglycerides go up, it becomes less and less accurate. The NCEP guidelines, I'm going to skip this because I don't frankly follow the guidelines. Like I said, the evidence-based medicine I use as a base, but I really try to personalize it. I show every one of my clients as pictures that you're told the HDL, LDL are what you want to follow, but guess what? There's actually 3 HDLs. One's good, 2 are bad. There's several different versions of LDL, and there's one that's the real killer. The other don't seem to be a problem. This is the VAP test. I'm not promoting the VAP test. I actually use a different one now. There's several different fractionation tests out there. Basically what they do, the Berkeley Heart Lab came up with the technique of ultracentrifugation of your blood to look at the cholesterol particles and particle size. So they spin your blood down and assay it out on a gel to look at each different particle size rather than this bogus cholesterol equation that we do on the right. And people get that. I have a little chart from the Berkeley Heart Lab that shows all the different particles, and once they see that graphically, it really helps them. This is what one of the tests looks like. And again, you can see the different markers that are on there. The lipoprotein A, which is really one of the most dangerous particles. The way I think of lipoprotein A and the way I tell my clients, it's like the bad LDL with a bad tail on it. The real LDL, the good HDL, then the density pattern, the pattern A versus pattern B. Small, dense LDL is what kills you. It's not total LDL, as well as the different apolipoproteins. You can look at 50 different things, but those are the ones that seem to be the most predictive. And again, possibly up to a 90% predictive value of who's at risk based on that test. This is the other way I like to show it. One of my clients came back from a urologist in Florida and said, God, he had this big wide screen on his wall in his exam room. And so instead of me trying to squint through my reading glasses at these little teeny pieces of paper, he throws these graphs up on this big screen. I sit there with a cup of tea and we talk about this. It's a great little model for your practice. People love it. It's not very expensive, a couple $100 for one of these big TVs. You mount it on the wall, you connect it VGA or however to your computer, and you sit there and you teach patients, provide them information. A graph like this is so powerful, so much more powerful than the words. For example, if you have an LDL of 140 calculated, what does it really mean? Well, I show them this. Well, the real deal with LDL are these. The lipoprotein A, which we talked about, is that bad LDL with the tail that kills you. The intermediate density lipoproteins. And again, the statin resistant. The most dangerous one tends to be statin resistant. Then in that LDL, the real, there's the small sticky marbles or the big bouncy basketballs. These are the ones that get you. The small dense LDL and the lipoprotein A. We don't care about your total LDL. We're trying to shift the LPA and the dense LDL. Here's the traditional model, and I won't go through this because it's in your notes, about when you have these different particles out, what is traditionally used as far as lifestyle changes, and then what prescription drugs are used for it. The other treatment options, omega-3 fatty acids, red yeast rice, niacin. I'll go over some of these others here in a second. So really the pattern A versus pattern B, it takes that small dense to the next level. You want large buoyant LDL, you want a normal triglyceride and HDL, and that infers a lower cardiovascular risk versus the small dense, high triglyceride and high HDL. The emerging risk factors, the C-reactive protein, the small dense, and the cornealcium score, lipoprotein A, fibrinogen, homocysteine. I run these on every single one of my patients as my baseline. If they're normal, I tend not to repeat them in the future unless they have a lifestyle change. Once they're negative, they tend to stay negative unless something else happens. I'm not going to go through this slide either, but this is what I was forced to memorize in my internal medicine residency about, again, putting everybody in a little bit of a box and try to look for these other risk factors. This is our clinic in Wilson. This is the hill that I got passed on that winter by the 71-year-old at 12,000 feet. This is my office right here in the corner, looking straight out the Grand Teton. My daughter goes to school right across the street. My brother's here in the basement. I think it's the American dream. Please don't come to Jackson. This is from 2008, the Business Week, and the popular press is getting this. The general population is slowly figuring this out. Lipitor for many people, cholesterol drugs may not do any good. And really what it is, it's about this. You can make any study look good. You can find a statistical analysis that can show almost anything to be better than almost anything else. How when you have to do a master's or PhD degree, you get stuck as a lab tech doing things? I got stuck doing EEG recordings on the severe PMS women to study Serafen for PMDD. Serafen is Prozac that they put a different name on it to make it more palatable for women to take for their PMS. So I had a pre-selected group of women with severe PMS that I had to put this little headset on and scratch their head to get the electrodes to fit and subject them to 45 minutes of misery. At the end of the day, after 6 months of doing those studies, there was I believe it was 38 versus 36.5% difference. The number needed to treat was about 300. The drug got approved. And that really gave me no faith. I was headed to do Alzheimer's research to look at inflammation in the brain with the studies of Joe Greer, Pat McGreer, and Joe Rogers down in Arizona, Pat McGreer up in Vancouver. They found that women that were identical twins, the one that took ibuprofen did not get Alzheimer's, the one that didn't did get Alzheimer's. Well, that was pretty fascinating. Aspirin didn't have the same benefit, but the ibuprofen medicines did. He was the one that taught me don't put your flag too high in any one hill, because it hasn't completely panned out. But when I was in college my first year, we thought the brain was a black box and it was immunoprivileged. We know for sure it has its own immune system now. It absolutely is not immunoprivileged. And what happens in your gut determines what happens in your brain. So what's the number needed to treat? This is the absolute gold standard to determine if a drug really works or not. So I've been arguing with my two brothers, the internists, for the last 10 years about statin drugs for primary prevention. The data has never really shown that the statin drugs have a primary prevention benefit. If you don't have heart disease, you haven't had a heart attack, and you're not diabetic, the drugs do not work. If you've had a heart attack and you are diabetic, there is some benefit, and I do use statin drugs. I think the statins are actually anti-inflammatory. I don't think it really makes that much of a difference on your cholesterol panel for benefit. It's really the inflammation benefit that you get from the statin drugs, but I do use those for patients. Here's the numbers. When used in people who've had a heart attack, 1 in 16 to 23 people treated for 5 years, you'll prevent one coronary event. To prevent an actual death, it's 48 people. So you have to treat almost 50 people for 5 years to prevent one death. And I'm not sure that that's not a bad odd. It's an expensive comorbidity. It's an expensive national liability. I just don't want to be that 50th person, and that's what everybody says. But when you look at when used in people without heart disease but have high blood pressure, it's 70 to 250, and it's actually closer to 250. When you look to prevent a death or serious medical condition, It's at least 1 in 500, and probably you can't even calculate it because there were no significant reductions in the deaths. How about Avandia? Who knows the Avandia story? How many people did it kill since it's been out? 70,000. And what did they die of? Heart attacks. So the drug that was approved to treat diabetes so you don't develop heart disease from diabetes killed people of what we're trying to prevent. It's off the market in Europe. It's still used in the U.S. It's just another indictment against using the wrong approach. Zetia, again, you need to treat 1,000 people to prevent one event, and you may actually not even prevent it. It was with Vytorin, which was Zocor and Zetia put together. Another example of how they knew that it didn't work. They knew that it was going to cause more deaths. They hid the data for 3 years so it could be on patent and generate fund and revenue. Once the data was published, they took it off the market. The Jupiter study, again, in patients with a normal LDL, it was not protective against cardiovascular disease. Well, I've already told you that. It's not about cholesterol. What they did find is that when your C-reactive protein's over 2, it was even less protective. When you took Crestor, it cut the CRP in half. Didn't I just say that these drugs are anti-inflammatory? That's the mechanism I think they work through. You had a 44% reduction. It was stopped because it thought it was unethical to withhold statins from any patient with a high CRP. What's the conclusion? Put everybody on Crestor. Again, I just don't think that that's the right approach. Fish oil will do the same thing. Your C-reactive protein, again, that's what makes that plaque irritable. It makes it want to rupture off the artery wall. It's your single strongest predictor of cardiovascular risk. It's chronic inflammation of that artery wall. Again, what happens in the heart, to me, happens in the brain. This is Vogel presented at that conference in Kona, and I had a long discussion with him about a lot of these studies. They basically put a catheter in people's brachial arteries inside their crease of their elbow, and they measured the pressure change. They gave them basically a Big Mac and measured the pressure change as far as the reactivity and volatility of that artery. They found brachial artery contraction and spasm up to 6 hours after a fatty meal, and that's just like my clients who call me walking home from the steak restaurant. As they're walking to their car, they get that chest pain because of that vasoconstriction caused by the arachidonic acid, the omega-6s in their meal. A little bit of more propaganda from the Lancet, talking about risk of coronary heart disease, stroke, and mortality. It has associations not only with coronary heart disease, stroke, and vascular mortality, but also several cancers and lung disease. Homocysteine, I call this the homocysteine game. It seems like there's 30-some studies out showing it's a benefit. There's a meta-analysis that's questioning it. And that gets to what we heard from our first speaker about you really got to watch how these studies are done, what they use, how the analysis is done, what version of what they use, what quality of what they use. It's very, very complicated that way. But it's an amino acid or a protein that's toxic to your artery wall lining. A homocysteine over 16 is a 40% increased risk of Alzheimer's. That's a known retrospective number. Then the meta-analysis came out looking at a strong causal association of heart disease, deep vein thrombosis, and stroke from 2002. That's when the homocysteine bandwagon was in full speed. A recent meta-analysis came out looking at all-cause mortality, showing no real benefit with homocysteine lowering therapy by B vitamins. B6, B12, and folate is the combination that lowers it. There's a drug that's marketed called Foltex, F-O-L-T-X. It's about $108 a month. The supplement cocktail we use is $7 a month. This is actually from Alan Gaby, who presented the Integrative Healthcare Symposium. I borrowed some of his talking points about this. Here's the reason why these studies, you got to be so careful not to, again, plant that flag too high. In a lot of the homocysteine studies, the N was underpowered. The homocysteine to start with was not in very high levels. The delta between the groups is small, so showing an effect is going to be difficult. Populations were not quite evenly matched, and they may have been too advanced with heart disease to show a difference. They did not control for other supplements clients were using, and you really need to measure homocysteine levels to know that you're actually making a difference, as well as blood levels of the vitamins that you're taking to try to make a difference. So it's very complicated to do these studies on these supplements, and it's like, how do you do a study of acupuncture? Well, do you do a sham acupuncture spot? I think it's just, the kind of complementary medicine, we'd love to have data to go to our colleagues and show that this is what works. And part of what David said is so true. We're all kind of doing our own little cocktail and our own little plan. What works in my hands doesn't work in Rich's hands, doesn't work in Tom's hands, and it's a little bit of a frustration that way. So trying to streamline these protocols is, I think, the challenge of our generation of physicians to do what we do. These are the same moose about 3 months later, getting ready for winter. I was fortunate enough when I was doing the work with Pat McGeer to, I bought a ticket from Seattle to Cancun, then hitchhiked to Belize, which I'll never do again. The most scary city I've ever been in is Belize City. But I went out to a little island and a boat broke down. I helped them fix it. The woman had lupus. I told her about my master's research. She said, "You've got to meet my doctor." So we boated to the mainland. They put me in a car. We drove to the Guatemala border, and I met this 101-year-old Mayan healer priest. His name was Danilao de Ponte. This is him holding his sastoon. It was a little marble he kept in this several hundred-year Mayan clay pot, and he would have people come from all over to see him. The first patient he saw was a woman with menstrual cramps, so severe she couldn't get out of the fetal position. So he did his exam on her, checked her pulses, looked at her tongue, touched her soothingly, and then we went for a walk in the rainforest. And he dug these two things up. These are Mexican wild yams. And he told me, everything that you need to heal, nature will tell you. It's called signature. What do these look like? I didn't realize it till 7 years later doing my OB rotation. That's what a gravid uterus looks like. He also had a set of vines that looked like the small intestines. That's what he treated dysentery with. There was a bark that looked like burned skin. That's what he treated burned skin with. And I was just fascinated by the legacy and the knowledge that we just are so ignorant of. Like Chinese medicine, it's not a coincidence it's been around for 3,000 years. How did we get Lipitor? Well, they heard about the Chinese heart tonic. They went over, got some, put it in the lab, ground and bound it, put a carbon on it, and patented it. They used red yeast rice as their natural structure to make the cholesterol drugs. Red yeast rice is a natural HMG coreductase inhibitor. You add a carbon to it, and it changes its bioavailability and its bioactivity. That's why you don't tend to have the side effects with the red yeast rice that you do with the statins, but you can still have them. Again, the omega-3 revolution. I had a professional athlete come in 10 days ago, and again, I was shocked at how bad his care was. He said he could only take his fish oil at night because it gave him bad breath and heartburn. I said, well, you're taking crappy fish oil. So I gave him real fish oil. He called me 4 days later and said, my girlfriend says I don't have bad breath anymore. So your quality of supplements, and the fish oil I think is one of the biggest ones, because you can get Chilean industrial harbor fish remnant parts that are full of mercury and arsenic, or you can get a krill oil or a North Sea sardine type based oil that's very clean and pure, and buy it from a company that assays every batch before and after it leaves. That's the real challenge for the quality supplements. But the omega-3, this is something I think should be in the water. One of my patients sent me this, and here's my acid test for vitamins. And I showed you that drum of vitamins earlier. I tell my clients, go home and look at your cabinet, or when they bring things to me, I actually have a bottle of Centrum in my office. I turn it over, look at what it says is in it for vitamins, then look at the other ingredients that are on there. If you see anything with F, D, and C, that's a bad idea right there. But a lot of these things, I tell them, if you cannot pronounce something on it, that's probably not a good idea for you. My son was asking me about titanium dioxide, why it was in his chewing gum. You know, again, there's some things that have to be there for preservatives, for certain supplements, but your base rule is if you see a big list of things on there, that's a bad idea. And your clients get this. You know, the fish oil idea, they get that right away. The vitamin idea, they get right away. Our vitamin we use for our multi-one a day, you flip it over, it says gelatin capsule. That's it. You know, and we sure love our natural herbs, and we wish everything could be taken by a supplement. And again, you can do much, much good medicine with supplements, but as I just showed you, there's bad supplements. These are 3 Centrum tablets, undigested in somebody's small intestine. The nurses call Centrum bedpan bullets. They go right through the body for some people. They just don't get absorbed because of all the binders that are in them. But what is Centrum? The #1 recommended vitamin in America by doctors. That's as good as we can do nutrition. Why? Because I got 20 minutes of nutrition in med school. They disguised it as biochemistry and called it scurvy. I got no training in nutrition. That's why I'm so passionate about it. At the same time, be very, very cautious of herbs and surgery. And the drug you've got to be the most cautious of is Coumadin. How many people know that glucosamine causes the Coumadin to be metabolized slower and increase your bleeding time? Very few people know that. Very few orthopedic doctors. When I was training at the Banner Good Samaritan, we had a gentleman come in for an abdominal aorta repair. They couldn't get him off the table because they couldn't get him to stop bleeding. He went through 112 pints of blood. No one knew why. All his clotting times were normal. I asked his wife, what vitamins is he taking? 8 grams of vitamin C, 10 garlic tablets, and 10 vitamin E tablets. So he was thinning his blood. No one told him to stop all his vitamins before. Ginkgo, garlic, and ginseng, when they examine pre-surgical patients, 1 in 5 are taking supplements. These are the ones most people take. And this is just for your reference. Really watch out for licorice with hypertension. And again, watching out for this hypoglycemia with diabetes meds. I can't tell you how many people have walked by GNC and got the chromium piconolate to help them lose weight, but they're on metformin already, and they get these low blood sugars and pass out. The other one to be sure you know about is St. John's wort. What drug do you watch out for St. John's wort? Especially in a 30-year-old girl. Birth control. St. John's wort will make birth control not work. What's the propaganda for omega-3? The data is pretty clear. Anti-inflammatory, anti-arrhythmic, decreased platelet, blood pressure, plaque stabilization, decreased triglycerides, vasodilation, modulation of autonomic function. A very powerful study in Italy. Men, of course all the studies are done on men, right? 3 months after an infarct, giving them omega-3, reduced death from any cause 20%, particularly reduced sudden death up to 45%. Finally, the Japanese got it right, and they did a study on women, 70% women, looking at statins or statin plus EPA at 5 years, an additional 20% benefit on beyond statins. Every single patient I have on a statin, I demand they be on a good omega-3, and I demand they be on coenzyme Q10, because we all know that statins deplete the muscle mitochondria of coenzyme Q10. It's in the literature. Bill Costelli, who was one of the Framingham authors, he came to Jackson to give a talk. He said he was at the table with the Lipitor reps. They were going to put it, CoQ10, in the pill. 3 cents more a pill, they decided not to. They knew this was going to be a problem. And again, those higher doses, it's an exponential increase. Crestor, which is the statin, of the statins, I think it's the most potent because of that Jupiter study showing the C-reactive protein lowering. I use Crestor every other day. It's got a 24-hour half-life, so you don't need to dose it every day. Some people can get by with 2 or 3 a week. That way you get the benefit and the protection without the possible side effects. It's all about food. Let food be medicine, your kitchen, your pharmacy, your lifestyle, your doctor. But really, as you heard earlier, food is information. This whole concept of epigenetics. Your genes are activated by the food washing over your body. Certain foods turn on certain genes. They turn them on or off. Louis Pasteur, our father of antibiotics, what did he say? It's not the bug, it's the soil. If I walk in here with the flu and I sneeze over everybody here, how many are going to get sick? Not everybody. It's the soil, not the bug. So it's really trying to increase the entire body burden, stress, mood, nutrition, gut. They talked about gastric bypass patients. We had a gastric bypass surgeon that was in Florida that moved to Jackson Hole to create this gastric bypass program. They bought him a Hummer and had him drive all over Wyoming trying to drum up business. What I found fascinating, I was the internist on call in the hospital, so I did the inpatient admission management. A gastric bypass patient that's 450 pounds, that's diabetic, hypertensive, hyperlipidemia, you do the gastric bypass, what do his numbers look like in 1 week? They're all normal. His blood sugar's normal, his triglycerides are normal, and his lipids will probably be normal. And it's not because he's not absorbing food, it's because he's turning on and off genes. It's fascinating. Well, you will see this with gastric bypass patients. Their numbers will normalize within 7 days. Then at the bottom here, this word, it says the agouti mouse. Who knows this story? Have you heard about this? There's a mouse that we bred to eat itself to death. It eats so much that it gives itself high blood pressure, diabetes, and heart disease. So what they did is they took that agouti mouse, They fed it B6, B12, folate, multivitamins, antioxidants to see what the offspring would be like. These are genetically cloned, perfectly, not cloned, these are genetically identical mice. The one on your right is the offspring with no diabetes, no hypertension, no hyperlipidemia. In one generation, by treating mom, we can change the outcome of the child. That also has reverse implications. If you look at the graphs of obesity in America, there was one state, Mississippi in 1970, that was obese. Now there's only one state that's not obese. And as Mark Hyman says, it's Colorado because they kicked them all out. So optimize nutrition. The key is simple. Figure out the glycemic index, how high your blood sugar rises. There's a website you can go to, but I ask every patient to look at this. Again, it's up on that screen. They don't have to go try to buy the book at Borders and figure this whole thing out. You just show them this. This is what a high glycemic index does to you. And the key is, what chases the glycemic index? Insulin. Insulin's your most inflammatory molecule your body makes. And again, you heard the IGF receptor story this morning. This is really why it makes such a difference, because when you have these high sugar loads and these high glycemic loads, you make a huge difference in your insulin sensitivity, insulin reaction. A couple of our babies. Mediterranean diet. 50% lower rate all-cause specific mortality. Statins are only 30. Really, just by lifestyle, we can do this. And this is an elderly men and women. You know, I tell my clients, I'm a doctor of moderation. I think everything that's legal you should be able to have a little bit of. You know, have a glass of wine, but drink really good wine, drink it with your lover, and make it a passion. The data says that a glass of red wine is cardioprotective. If you're an Italian living on the Mediterranean, it doesn't tell me anything about an Italian living in Jackson Hole. So you can't really know what it is, but the data seems pretty good that a glass, maybe a second, is maybe helpful. We know, though, that alcohol is a toxin. More than two is toxic to the brain, but particularly toxic to the wiring of the heart. That's why people who drink heavily develop atrial fibrillation, because it erodes that plastic coating of the copper wiring. And I think a big reason that we have an Alzheimer's epidemic in America is because of alcohol and alcohol consumption, because of high glycemic foods, because of the insulin inflammation. Really, Alzheimer's, it's not about plaques and tangles. This whole amyloid theory of Alzheimer's, I think, is a crock. There's a multifactorial process that ends in this cascade that we determine is Alzheimer's, but it's a multifactorial. It's toxicity, it's our diet, it's what we're exposed to, and it may be a little bit of the genetic basis to it too. Some people just may be the canaries in the coal mines. But if that was true, why did the twins, when one took ibuprofen, they didn't get the Alzheimer's? What about Down syndrome? What do we know about Down syndrome? If you live past 35 or 40 as a Down syndrome patient, what will you get? Alzheimer's. Pathologically indistinguishable from an Alzheimer's brain. And do you remember the aluminum story that came out? They said, well, it's the aluminum cookware because a study in Scotland that they did pathology biopsies on Alzheimer's brains showed high levels of aluminum. Guess what? They show high levels of 7 or 8 metals as well. It's not about the aluminum. So you don't need to throw your cookware away, except maybe the Teflon. Again, another Mediterranean diet study. We just know that it's the brain, heart, joints on fire, and that you can fix this by your nutrition. You know, Mark Hyman, last time I heard him talk, I love the way he thinks about things. Forget about naming disease. Just look at the target pathways. There will be no future blockbuster drugs, just blockbuster pathways and blockbuster mechanisms. I tell my clients, as David said, I don't really care what disease you're labeled with when you come. I want to look for why you have it. You have a thyroid problem. Why do you have it? Oh, my TSH was high at the health fair. Well, why is it high? Fibromyalgia, chronic fatigue, they don't exist in a lot of our practices. As an internal medicine doctor, I've got zero to offer you. I had a drug for irritable bowel syndrome, but it killed too many people and we took it off the market. So as a primary care practitioner, I'm one of those people where I read the alternative journals, the integrative medicine journals, I read JAMA, I read Annals of Internal Medicine, American Family Practice Physician, and I see the traditional journals. There was a review on irritable bowel syndrome, didn't even mention probiotics, didn't even mention food sensitivities, and that fixes probably 85% of the people that come into our office with irritable bowel. A little propaganda on the nutraceuticals: soluble fiber, garlic, plant sterol, soy protein, Google lipid, polycosanol niacin, red yeast rice extract. In my hands, and I know we're all different, there is no one thing that works for everybody. I kind of have my go-tos that I use, and it depends. If someone comes to you with a high triglyceride and a low HDL, that's very different than someone who comes with a high LDL. So you have to treat them differently. Everybody should get an exercise prescription written out on your prescription pad with a game plan of how to exercise that works for them. I tell them add this much each time so that you go from here to here, but in this much increment, add a couple minutes to each exercise session. I tell everybody about the glycemic index. I tell everybody how to do deep breathing. We try to do these things for all of our clients. If you have a high triglyceride, low HDL, that's your omega-3 fix. That's your niacin fix. If you've got a high LDL, that's your red yeast rice fix. And the plant sterols. Google lipid, polycosanol, I've had really mixed results in my own hands. Some people respond amazingly to it, some people don't. It's like melatonin. Does everybody respond to melatonin? Not everybody. I have a 50-50 rule. 50% of people respond great to melatonin. 50% of people does nothing for them. Soluble fiber, that's oats, psyllium, pectin, guar gum. The doses used in some of these earlier studies, 2 to 10 grams. Like I said, you can go back and look at all this literature. I did this over the last 2 months, and I got kind of overwhelmed at these studies because I found a bunch of studies that showed good things, a bunch of studies that showed no benefit, and a bunch of studies that showed some downside. But again, American Clinical Nutrition Journal 99, 15 to 18% just with some soluble fiber. The plant sterols, I'm a big fan of these. You can decrease your LDL by 10% as well as lower your CRP. The only thing endorsed by the NCEP, that's your soy, nuts, beans, rice bran. My personal motto of soy is I don't think we really know about soy right now. I think edamame and probably tofu are good soy sources. I think soy milk is a bad soy source. Soy may be an endocrine disruptor for thyroid and estrogen as well. Red yeast rice extract. My first patient I put on this, his cholesterol went from 254 to 193 in 2 months. I thought, oh my gosh, this is going to work for everybody. About 90% of the people it does. An omega-3 red yeast rice extract. 10% of the people it doesn't. Then we've got to dabble with some of these other things. But again, everybody gets exercise prescription, glycemic diet information, and Mediterranean diet counseling. I have a nutritionist in my office. You cannot see me if you won't see my nutritionist. I need to have her on board to help you be successful. And most people like it. We don't charge much for it. It's a great team relationship. I also have a biofeedback heart math in our office. I have a psychologist that comes in. We have massage service available. And I think that whole team approach is what works. It's hard to do, though. And we all lose a little bit of money providing a higher level of care by doing that. The red yeast rice extract is this white rice fermented by the yeast Menolascino. It's really the monocolin K, the omega-3 fatty acids, and some sterols that are in there. This is an old study showing pretty good benefits. A recent article showing simvastatin 40 versus the Mediterranean diet, exercise, 2 grams of fish oil, and the red yeast rice extract in 2008. Pretty alternative journal there, the Mayo Clinic journal. 42% versus 39% LDL, basically the same. It worked as good as the statin. But here's what's more important, the triglyceride worked way better. I mean, it lowered the triglycerides 29% versus 9%. There was a little more weight loss, and that's the exercise factor. More importantly, there was one person with a high CPK, which is the muscle myalgia problem, and one complaint of heartburn, versus 5 patients with frank myalgia and 5 with elevated LFTs on the statin. So again, looks at least the same as good with the LDL, better for a couple other things, and less side effects. And then in statin intolerant patients, like the gentleman I told you with the CPK that was so high, they took 31 patients that had that statin-induced myopathy, and they put them on red yeast rice versus placebo. They lowered the LDL 35%. The total cholesterol improved a little bit better in the red yeast rice group, but the muscle pain scores were the same, and liver enzyme tests were the same. So I find in about 10 statin intolerant patients, one will have the same results. So you will get the same trouble with these. This is the blue healing Buddha. Google lipid, another one of these things where some patients have had amazing results, some don't. Polycosanol, kind of interesting story. The studies that showed polycosanol worked were all European studies because they had access to the Cuban polycosanol, which was sugarcane derived. The American polycosanol is beeswax derived. Doesn't seem to work as well. Again, another polycosanol. You'll see through the literature there's all kinds of studies that show a benefit. You got to kind of be as skeptical as you do with the drug trials. Garlic, a lot of people like garlic. I see very little downside to it. Allicin's the active ingredient. Soy, again, we've seen similar benefits, particularly with fasting insulin resistance. Niacin is my favorite, but I can't tell you how many people have called me pissed off because I made them sick by niacin. And so what we've done is we've gone back to 100 milligrams, and we start them and increase them 100 milligrams a week. We go painfully slow. We have them take it with their dinner. If they have an extra cocktail or spicy food, we tell them not to take it that night because that's typically when we have flush. I've had one patient actually get hypotensive and vagal into syncope with niacin. We talked earlier this morning about calorie restriction. That's had some impressive benefits on both lab tests as well as the carotid scan. Here's two monkeys, Kanto and Owen. Same age, calorie restriction. Which one do you want to be? Denham Harmon was the father of this whole calorie restriction free radical theory. He was an old researcher at University of Nebraska. We kept bumping into each other in the same dusty journal aisles, and he should have got the Nobel Prize. Again, has the medication had any other side effects? Don't forget our supplements can too. Antioxidants and cardiovascular disease. We've shown some benefit, and again, all these studies that I wanted to memorize so I could quote them and look smart. Some show it, some don't. Are they bad for the heart? Well, look at they used alpha tocopherol. Most people in this room know alpha doesn't work. It blocks the action of gamma delta, which are the two that do work. They were study limitations, advanced coronary disease, diabetes. It was secondary, not primary. The duration was too short, the wrong type of tocopherol, and don't look at the other synergy. I kind of scattered in here some of these limitations of studies, and you look at these articles in all the journals that we read, both medical and integrative. Think about these things as you read in the journals. Look at the studies to see if they're thinking about this and controlling for these factors. It's very difficult to. Vitamin D has all kinds of benefit. David Perlmutter at the Natural Supplement Conference in San Diego last January showed some incredible data about the brain in MS patients. I've used it the same. I've seen fantastic benefits of vitamin D with mood, with MS, other neurological disorders. Does calcium cause heart disease? I've told most of my men in general don't take calcium, but I don't think we really know. Again, the data derived from post hoc analysis, you just can't really trust them. A meta-analysis showed an increase of 30%, but there were some problems with it. Again, post hoc analysis are more likely due to chance versus a primary analysis. And again, I apologize to blow through these quite quickly, but our time's getting short. I want to save some time for questions, and basically what I'm telling you is all in there. If there's anything else that's not written down, I'll be sure to mention for you. Again, there is a trial with 2,000 patients. That was done in 2011 that did show a 6% decrease. Just to kind of change tracks a little bit, because we really got to think about this all in text. You remember the fight or flight response? That's a really good one, because when the elk jumps out in front of me, it makes me heart rate go up, my eyes dilate, my reflex is sharper, and that's what helps save us from the saber-toothed tiger. But if you're running behind the malathion truck, like a lot of our clients have, and again, 50 years ago they were doing this, now they're developing the cancers. You throw some hormone imbalance, nutrition imbalance, a toxic environment, a little depression, anxiety, anger, hostility into the mix. No wonder we're exhausted and sick. Don't forget about hypothyroidism. I've probably taken 500 people off of Lipitor by fixing their thyroid. Your cholesterol is the fuel in the factory that gets burned. If your factory's not hot, you won't burn the fuel. A lot of times you fix cholesterol by fixing the thyroid. Plus, when their thyroid's fixed, they're happier, they have more energy, they exercise more, they'll start making better food choices. That whole big wheel we talked about starts to spin faster. Again, it's very complicated. If you're just looking at the TSH, as you guys all know, so many doctors hang their hat on it. It absolutely does not tell you anything. But a target tissue of the thyroid is the heart. This is from Heart Math, about teaching people how to live parasympathetically, not sympathetically, and helping to balance the autonomic nervous system. I find a lot of utility in these salivary DHA and cortisol values and trying to optimize and balance people's adrenals. You can pretty much just ask someone these questions and you can know what their adrenals are. If they're tired in the morning but they sleep a little longer and they'll get a second wind, they're low cortisol in the morning. If they get home from work and they're fatigued but they get a second wind in the evening and can't fall asleep, they're high cortisol at night. So push their morning up and drop their evening down. Use some type of adrenal. I used to use a lot of glandulars for the adrenal, but I'm not anymore because I think it kind of suppresses the adrenal unless they're in stage 3 failure. I use a lot more of the stress adaptogens, the ashwagandha, rhodiola, theanines, to try to adapt the adrenal rather than put it to sleep. Phosphatidylserine is what you give people in the dinner and evening to drop that nighttime cortisol. Again, this is our home here. I had the good fortune of Darren Larson, one of the health educators for Designs for Health, and I love that term because it is about education. We did this dump the junk detox, and I never was a fan of detox programs. I thought it was a gimmick for health food stores to make money. But just like the heavy metal toxicity thing, I think the detox programs are good, and I particularly like this one because it's not a 6-day juice fast or some aggressive detoxification of the body. Everybody feels like crap for 2 days on a detox. It's the kind of Herxheimer reaction you get like when people treat candida. But this was a program we did. We did basically a lecture to the community and had people come. Designs for Health was kind enough to provide supplements for 10 clients, and then I provided the labs and biometrics for 10 clients. It was a 21-day detox. We had 10 people in our program, but we had almost 60 people in the community do it. It's interesting because a lot of the people who went through the detox continued to eat dairy-free, egg-free, gluten-free, drink enough water, and again, it's just, I see them, they grab me in the grocery store and thank me for helping them figure this out. It's been a really satisfying thing. Some of the numbers we saw, this is, I got 3 different people here. 235 when he started, triglycerides of 316. 21 days later, lost 18 pounds in 21 days, triglycerides now normal. He did drop his cholesterol 50 points, didn't do much for his HDL. Another gentleman, 211, look at that blood sugar. He was type 2 diabetic on no medications, and look at the fatty liver. Down to 194, 17-pound weight loss, almost completely fixed his fatty liver. Look at this blood sugar. Again, food is medicine, better than medication. This is actually one of my best friends, weight 242, high triglyceride, 256, 161. Look at that. 197, 103. Interestingly, his triglycerides bumped up a little bit. I don't really have an answer for that. But this was 3 days after he stopped, and he cheated his diet a little bit. So it bumped up. It might have been just kind of an aberration from the meal the night before. But again, I can't get, in 21 days, I can't get this result with Lipitor, no matter what dose I give him. Plus weight 242 to 218. And he's maintained it. He started smoking cigars, though, which I got to work on that one. And again, another similar thing. The fatty liver, I'm not sure if you guys are really toned in on this. His ALT is 60 down to 47. Again, 47, 26 there, 60 and 37, 47 and 26. I mean, essentially, it's a cure for fatty liver. Fatty liver is a difficult beast for us to tackle, and I think, again, detoxification is all about the liver, phase 1, phase 2. The liver takes bad things, brings it through phase 1 to turn around and put water on it so your body can get rid of it. By healing the gut, spinning the liver, most things get better. Thank you very much. We'll take time for a few questions if anyone has any.
As a gynecologist, I have developed now what I would call a love-hate relationship with birth control pills. Because as time goes by, I see them more and more as endocrine disruptors, and I have concerns about their long-term effects on the cardiovascular system. And I wondered if that was an area that you had any information on.
Well, you know, there's probably 4 gynecologists in my town that hate me because I've taken their patients off the Mirena IUD because it was poisoning them. But these women's husbands love me. For a lot of women, the Mirena, it has a synthetic progesterone. It's really these progestins that, if you open the textbook of endocrinology, it'll say known carcinogen. We know the progestins are a bad molecule. And the birth control and the Mirena, they occupy the receptor and don't let the good progesterones in. So I have a love-hate relationship with birth control. I try to get all my patients off of it. I try to have all my male patients get vasectomies if they're, if that's the issue, if it's a fertility issue in a long-staying healthy couple. But no, I'm very concerned about the epidemic of birth control. You know, as a gynecologist, and please don't take this personally, you have 2 tools, surgery and birth control. And you know, you got fibroids, surgery. Well, fibroids are fixable. Menstrual regularity is fixable. I'm a big fan of progesterone. I'm now board certified in anti-aging hormone therapy. I'm trying not to use hormones. I'm trying to think upstream, like David was talking earlier. How can we help this body get back into balance without giving it another medication? I like bioidentical estrogen. I think it occupies the healthy estrogen receptor and prevents xenoestrogens from getting on it. If you talk to a lot of the compounding pharmacists, they'll tell you, we don't see much breast cancer in our clients. And they think the same thing. Jonathan Wright mentioned that to me at lunch about a year ago, that he thinks it's occupying the receptor and preventing xenoestrogens from causing hormone disruption and increasing cancer risk. But I think, you know, the next evolution of this whole bioidentical hormone movement will be not to use them and find ways upstream to support those estrogen systems rather than replacing the hormones.
You know, concerning the Mirena IUD, when that first came out, the pharmaceutical company that makes it claimed that it had no systemic effects whatsoever. It was purely a local effect, but that is absolutely not true for people who do use it, because it prevents ovulation in at least 50% of women. It's definitely a systemic effect.
Well, we know oral Premarin reduces serotonin in the brain. That's a known fact. I find a lot of young women, when they're on the Mirena, year 2 to year 3, they get depressed or dysthymic. And most women in America are not depressed, the ones that are on Lexapro and Prozac and Cymbalta. They're dysthymic. And if you get that symphony, the beautiful symphony known as women's hormones, back into balance, dysthymia goes away. We thought we had a test for depression and dysthymia, and we did our master's. It was a dexamethasone suppression test. If you cannot get the adrenal to behave, then you probably have dysthymia or depression. So there's a real link between the HPA. You know, it used to be the HPA axis. It's now the HPATG axis. The hypothalamic, pituitary, adrenal, thyrogonadal axis. And if you're not thinking about people in that axis, then you're doing the wrong thing. You know, every one of my other anti-aging colleagues is big on the human growth hormone, and you saw some data today of why that should be such a scary molecule. I do not use growth hormone in my practice. I do test for it, and we find when we get the rest of the symphony back into balance, the growth hormone comes back up. And so, you know, that would be my message to your clients that ask you about growth hormone, or friends of yours that are on growth hormone. Try to help them get their symphony balanced, and you'll find that it'll come back up. Thank you all very much. Enjoy your evening.